Good day. This is Dr. Ahmed Shafei, lecturer of otorhinolaryngology. Today we're going to start the new section of our module with the pharynx and larynx and the trachea. We'll start with the anatomy and the physiology. The larynx, sometimes referred to it as the voice box. It's forms the last part of the upper airway. It's composed of a framework of cartilages, which is either single cartilages or a pair of cartilages, as the arytenoids and the corniculates, and the main structure is formed by the single cartilages like the cricoid and thyroid and the epiglottis. On these three diagrams, we can see the epiglottis, which is protruding from over the hyoid bone, and this is the thyroid membrane. This is an anterior view, and the main cartilage, which is very prominent, and it's like a shield in the anterior parts of the larynx. This is the thyroid cartilage, and this is the cricoid cartilage. The cricoid cartilage is a signet shape, which is formed of an arch and a lamina, with this articulating surface with the arytenoid cartilage and this the other side, and this is the corniculate cartilage. From a posterior view, this is the epiglottis, and from a lateral outside view, this is the thyroid cartilage, and this is the cricoid cartilage. This part we refer to as the cricothyroid joint. This is the trachea, and this is the epiglottis. This is a median sagittal section through the larynx, where it shows this is the vocal ligament. It's attached from the vocal process of the arytenoid cartilage to the posterior border of the thyroid cartilage. This is the cricoid cartilage. From a lateral view, this epiglottis, it has two attachments. One through the hyoepiglottic ligament to the hyoid bone, and this is the attachment to the thyroid by a ligament, which is the thyroepiglottic ligament, and in front of it, this is the preepiglottic space. The thyroid cartilage, it's a shield shape. It's open posteriorly with an anterior angulation. It's more acute in males. It's a shield for the larynx and provide attachment to the vocal cord. Cartilage is the only complete ring in the larynx framework. It's stronger than the thyroid cartilage. It's broader and thicker posteriorly in the lamina. It's more broader than the arch. From structure and functional importance, it's the base for the entire larynx, support for arytenoids, attachment to the intrinsic muscles of the larynx, which is the main function for controlling the phonation, and it's the only complete ring in the larynx. Once injured, it's very hard to resect this this strictured part while still preserving the laryngeal function. So it's a vital part of the larynx. The epiglottis is a thin leaf-shaped fibrocartilage. It's a midline structure. It has a free upper end, which is broad and rounded, and project behind the tongue base. Half of the epiglottis project above the hyoid bone, and it has a laryngeal surface and a lingual surface. We can see it has a part that's towards the larynx, and the other part is towards the tongue base. It has a narrow base, and this is the pre-epiglottic space, which form between the attachment of the epiglottis to the hyoid bone and the attachment of the epiglottis to the thyroid cartilage through ligaments named the hyoepiglottic ligament and the thyroepiglottic ligament. Arytenoid, it's a pair of cartilages which is pyramidal in shape. Its base articulates with the cricoid cartilage, forming this cricoarytenoid joint, which has a major function in phonation. It has two processes: an anterior elongated process called the vocal process, have the insertion of the vocal ligament, and a muscular process which receives the attachment of the posterior cricoarytenoid muscle and the lateral cricoarytenoid muscle. The laryngeal cavity is divided into three parts: above the vocal folds and below the vocal folds, and the vocal fold area is called the glottic space, and above it is the supraglottic area, and below it it's the subglottic area until the first tracheal ring. So, explaining the supraglottic space, this is the true vocal folds. Above of it is the laryngeal ventricle with the Vohl's vocal folds. This is the epiglottis. This is the laryngeal surface of the epiglottis, and this is the epiglottic fold. Arytenoids to the epiglottis, so this is the epiglottic fold. The glottic space, it's formed of the true vocal folds. It's a triangular space formed of the true vocal folds when the anterior commissure and the posterior commissure. The anterior two-thirds is membranous, and the posterior two-thirds is formed mainly of the vocal processes of the arytenoids. The subglottic space, it begins only 5 mm below the free margin of the vocal folds. It consists of a mobile upper and fixed lower part. Two groups of laryngeal muscles: the extrinsic muscles, which is shared with the pharynx, with the other constrictor muscles of the pharynx, and the other pharyngeal muscles, functioning for elevating and depressing the larynx, helping its protective mechanism from aspiration, and the intrinsic muscles, which is mainly functioning in controlling the phonation and fine-tuning of the pitch of our voice. The mucosa of the glottic and supraglottic space are stratified squamous epithelium, and the ventricles and subglottic regions are pseudostratified ciliated epithelium. Supra and subglottic regions, particularly, are rich in submucosal mucus and minor salivary gland, while glottis are free of any mucus or salivary gland. The intrinsic muscle is a little bit sophisticated. To make it easier, it can simply communicate different cartilages, so it can control the phonatory function of the larynx mainly. So this is the thyroarytenoid muscle connecting the thyroid cartilage to the arytenoid cartilage, and the cricoarytenoids muscle, which is a posterior group and a lateral group, and this is the cricothyroid muscle, which is cut in this section, and also this is the arytenoid, and this is the epiglottis, so this is an epiglottic muscle. And this superior view shows more details, and this is the thyroid cartilage. This is the lamina of the thyroid cartilage, showing this group of muscles. Starts with this is the vocal ligament here, and then this is the vocalis muscle here. Lateral to it is the thyroarytenoid muscle, and outside to it this is the cricothyroid muscle, and posteriorly this is the posterior cricoarytenoid and the lateral cricoarytenoid group. Also, a posterior view, this is posterior cricoarytenoid muscle, transverse arytenoid muscle, and this is the aryepiglottic muscle, and also there's oblique arytenoid muscle. The cricothyroid muscle, which helps controlling this cricothyroid joint. This is the pivot point. It's action mainly for lengthening and tensing the vocal ligaments. It's a major function controlling the phonation. And the vocal folds has adductors, so it helps for the protective mechanism of the larynx. And this is an action of the transverse arytenoid muscle, adduction of the vocal ligaments, and also the vocalis muscle and the thyroarytenoid muscle, which are relaxers of the vocal ligament, have a major function in phonation. And this is the lateral cricoarytenoid muscle, which is adduction of the vocal ligament by controlling the movement of the rotating the arytenoid cartilages and then adducting the vocal ligament and tensing it. The action of the vocalis and the thyroarytenoid muscle are shortening or relaxing the vocal folds. Also the cricothyroid muscle and the lateral cricoarytenoid muscle, which is abducting the abductors of the larynx. We can mention the posterior cricoarytenoid muscle, which is help in lateral rotating of the vocal process, so it helps for abduction and widening of the glottic space. Posterior cricoarytenoids are an abductor of the vocal ligament. With the P and B, you can use it as a hint. And the joints are the cricothyroid and the cricoarytenoid. The cricothyroid is between the thyroid cartilage and the cricoid. Its main function, it has rotation and gliding movement, and the cricoarytenoid joints, it has also. The laryngeal joints, mainly they have two movements, is rotation and gliding. This is the cricothyroid joint and the cricoarytenoid joint. The cricothyroid is between the inferior corner of the thyroid cartilage with the facet of the cricoid cartilage, the junction of the arch and the lamina of the cricoid, and the cricoarytenoid joint. It's at base of the arytenoid cartilage and the facet of the upper border of the lamina of the cricoid cartilage. Spaces related to larynx are the pre-epiglottic space, Larynx space. Pre-epiglottic space are bounded superiorly by hyoepiglottic ligament and anteriorly by the thyroid membrane and the thyroid cartilage, and posteriorly by the epiglottis, mainly filled with fat and aerial tissue, and it's continuous with the paraglottic space downwards. It's very important space, which it gives space for spread of laryngeal cancer through this pre-epiglottic space. The running space is the mucosa, a loose mucosa over the vocal ligament, whereas there is a submucosal space, which most of the true length of the vocal space bounded laterally by the thyroid cartilage and medially by the glottic space with the vocalis muscle and the thyroarytenoid muscle. In case of laryngeal cancer, if there is an invasion of this space, it differs in the staging, and it affects the outcome of different treatment modalities. Supply is mainly derived from the vagus nerve, which is the superior laryngeal nerve, which leaves the main trunk of the vagus high in the neck, and it's divided into two branches, which is the internal and external laryngeal nerves. The internal laryngeal nerves, it provides sensation to the glottis and the supraglottis, so above the level of the vocal cords. including the pharynx and the epiglottis, and the larynx above the chords. We can remember it by superior laryngeal for SIS, superior internal sensory. For the external branch, it supplies the motor function for the cricothyroid muscle, which is the main tensor for the vocal cords, and in case of its affection of this nerve, it may cause to a laryngospasm. Laryngeal nerve, it gives sensation for the larynx below the level of the vocal cords, the subglottic area mainly, also for uh, uh, the pharynx and the esophagus. It provides also a motor function to the intrinsic muscles of the larynx. The right side, it enters the mediastinum, turns back into the neck, and travel inferior to the subclavian and loops up, and the left side provides inferior to the aortic arch and loops up. The blood supply, superior laryngeal artery branch from the superior thyroid branch of the external carotid artery, and the inferior laryngeal is branch from the inferior thyroid artery, which is branch of the thyrocervical trunk. This diagram shows the subclavian, which has a branch, the thyrocervical trunk, giving the inferior thyroid artery, giving the inferior laryngeal artery, and this is the common carotid bifurcating into the external and internal carotid, and the superior thyroid artery gives branch to the superior laryngeal artery. With the same idea here, the venous drainage is completely the opposite. The vein, superior laryngeal vein, drains in the superior thyroid vein into the internal jugular, and the inferior laryngeal vein drains into the inferior thyroid vein, then to the brachiocephalic vein. The main concern here, in case of tracheostomy, there is a main concern for bleeding while doing the tracheostomy procedure. There are different groups for the lymph drainage. Above the vocal cords differs from below the vocal cords. Above the level of the vocal cords, it drains to the superior deep cervical lymph nodes, and below the level, those are the pre and paratracheal nodes, which drain into the inferior deep cervical nodes. Here is formed of a cervical part and the mediastinal part. It's a down continuation of the subglottic region. It's a C-shaped ring that makes the airway always open. Some people call it a windpipe. It's divided into two main bronchi at the carina. Functions are pretty obvious. Respiration, as it's part of the respiratory tract, protection from aspiration, preventing food from entry into the lower airway, phonation, and for fixation of the chest in case of straining, like lifting, like anything that needs an expelling force, like during childbirth, and the closure of the glottis for the protection and also helping phonation. It's a part of our upper respiratory tract, so it's obviously it has its functional respiration. Protection against aspiration, it acts as a sphincter by the closure of the laryngeal inlet, by closure of the glottis, and cessation of respiration, stopping respiration, and the cough reflex to expel any foreign bodies to enter inside the airway. For protection, there is three sphincteric levels for airway protection at the level of the epiglottis and the laryngeal ventricles and the true vocal folds. Initiating this cough reflex, At the laryngeal inlet, especially on the laryngeal surface of the epiglottis, uh, it has a sensation. In case of any foreign body, the cough reflex will be initiated. The efferent system will respond by elevating the larynx and adduction of the vocal folds. So it acts as a sphincteric protection. And for the phonation, the voice produced by vibration of the vocal folds. It's the tone of the voice is mainly produced by the larynx. It's modified by the resonating chambers in the upper airway tract. The phonation, the cricothyroid muscle lengthens the true vocal folds. So this acts by increasing the pitch. And the thyroarachnoid muscle, it has increased the internal tension of the true vocal folds, causing the cord thinning, also increasing the pitch. Here is for laryngeal voice production. It's the myoelastic aerodynamic theory, where the laryngeal muscles, at the position of the vocal folds, during expiration, there is a subglottic pressure that develops below the level of the vocal folds, which is increased, and this subglottic pressure exceeds this muscular opposition, so this glottic chink is forced to open with the release of air and the vibration of the vocal folds and the control of the lengthening and tension of these vocal folds, in addition to resonation of the chambers in the upper air digestive tract. All of this gives different phonatory control of the developed voice. For the neuromuscular theory, it suggests that with central neuronal control through the vagus nerve, it will induce vibrations in the vocal cords, and actually this theory is disapproved by different physiologic and idiometric analysis. The relaxers and tensors of the vocal ligament control mainly the frequency of sound produced by the larynx through the action of the thyroarachnoid muscles and the cricothyroid muscles. Now we start the pharynx. The site of the pharynx is in the midline of the neck, from skull base to the esophagus, in front of the upper 6 cervical vertebrae. So, according to the site, it's either behind the nose, or behind the mouth, or behind the larynx. This is the nasopharynx, oropharynx, and the laryngopharynx, or hypopharynx. And this compartment, as seen from behind, naso, oro, and laryngeal. So it's a funnel-shaped muscular tube, 5 inches in length. It starts at the skull base and ends at the level of the C6 cervical vertebrae, as for the esophagus starts. This is the soft palate. This is the epiglottis, where the soft palate divides the oropharynx from the nasopharynx, and the epiglottis. When you start the laryngeal surface of the epiglottis, it starts the hypopharynx, and above it is the oropharynx. Naso, oro, hypo. Nasopharynx is the space behind the nasal cavity. It extends from the skull base superiorly to the soft palate inferiorly. It communicates with the oropharynx through the velopharyngeal sphincter. This is the adenoids, or the nasopharyngeal tonsils. It's in the roof, and also in the lateral wall there is the pharyngeal opening of the eustachian tube. and it's called a tubal elevation. The hypopharynx is behind the larynx in front of the third to sixth cervical vertebrae. It's from the tip of epiglottis superiorly to the lower border of the cricoid cartilage inferiorly. It communicates to the larynx anteriorly, superiorly to the oropharynx, and esophagus inferiorly. It also projects posterior and lateral to the larynx, forming the postcricoid region and two piriform fossae on either side of the larynx. Of the pharyngeal wall. It's first by mucous membrane and fibrous layer which formed of the pharyngobasilar fascia and the muscular coat and the buccopharyngeal fascia. This is a diagram of the structure of the pharyngeal wall, which this is the cavity and this is the pharyngobasilar fascia, the muscular wall, and the buccopharyngeal fascia. Concerning the muscular coat of the pharynx, starting by the constrictor of the pharynx, there are three constrictors of the pharynx: the superior constrictor, the middle, and the inferior constrictor of pharynx. The origin of the superior constrictor of pharynx at the pterygomandibular ligament. It has two attachments to the pterygoid hamulus and posterior end of the mylohyoid line in the mandible. The middle constrictor at the angle between the stylohyoid ligament and the lateral horn of hyoid bone and the upper border of hyoid bone, and the inferior at the oblique line of the thyroid cartilage, which this part called the thyropharyngeus, and also the cricoid cartilage. There are gaps between the pharyngeal constrictors, with structures emerging in between these constrictors, with the stylopharyngeus muscle and the glossopharyngeal nerve between the superior and middle, and the superior laryngeal artery and internal laryngeal artery between the middle and inferior, and the external laryngeal nerve over the inferior constrictor of the pharynx as it traverses between the thyroid and cricoid cartilage through the thyroid membrane. This is a posterior diagram showed the attachment of the three constrictors into a pharyngeal raphe, which lies posterior. It's a common insertion of the three muscles, making a muscular tube. These circular constrictors, they are superior, middle, and inferior. They extend around the pharynx and inserted posteriorly into fibrous raphe, extend from the pharyngeal tubercle on the occipital bone to the esophagus. The three muscles overlap each other's. The gap between the superior border and the superior constrictor and the occipital bone is filled by a thick pharyngobasilar fascia. The diagram shows the palatopharyngeus muscle and the salpingopharyngeus muscle from the cartilaginous opening of the auditory tube. Motor supply, as stated before, it's mainly through the pharyngeal plexus by the cranial of accessory, and only exception is the stylopharyngeus by the glossopharyngeal. So this is the sympathetic innervation through branches from the superior cervical ganglion. The glossopharyngeal nerve carries the motor control, the vagus nerve for the parasympathetic control, and the pharyngeal plexus, which is received branches from the vagus glossopharyngeal sympathetic fibers. So this pharyngeal plexus lies on the outer surface of the middle constrictor muscle. It has a branch from the vagus which carries motor and parasympathetic, a pharyngeal branch from the glossopharyngeal, which is mainly sensory, and a pharyngeal branch of the superior cervical sympathetic ganglia. The sensory innervation is through the maxillary nerve, the glossopharyngeal nerve, and the vagus nerve. So the maxillary nerve have a pharyngeal branch. It's have a sensory sensation to the nasopharynx, and the glossopharyngeal nerve, so the pharyngeal branch to oropharynx, and the vagus to the hypopharynx. So the blood supply, arterial from branches from the external carotid artery, has two ascending arteries, one ascending pharyngeal and ascending palatine, and the facial, maxillary, and lingual, and the veins in an opposite direction. It forms a pharyngeal venous plexus which drain into the internal jugular vein, and lymphatics drain into the deep cervical lymph nodes either directly or through the retropharyngeal and paratracheal lymph nodes. For the vulvar tonsillar ring, which shows the lymphatic tissue, it forms a ring in the pharynx, which is mainly by the nasopharyngeal adenoids, and the tubal tonsils, which is not apparent in this diagram, which is situated next to the sticking tube orifice, and those the palatine tonsils and the lingual tonsils. Another diagram. So this protective function of the lymphatic tissue are very important for the upper respiratory tract, especially in the early years of life. So this is the palatine tonsils, soft palate, uvula. This is the tongue. The palatine tonsils are a mass of lymphoid tissue surrounded incompletely by a capsule. It has an almond shape. It lies on the lateral wall of the oropharynx in the tonsillar fossa with the palatoglossal arch and the palatopharyngeal arch and the tonsil. The relation, it lies in the tonsillar fossa. Anterior to it is the palatoglossal, posterior to it the palatopharyngeal, and those are the tonsillar crypts. Lateral to it is the superior constrictor muscle and the facial artery which gives the branches for its blood supply. So the diagram for the palatine tonsils, those are the crypts. This is the superior constrictor muscle, and this is the facial artery giving its branch to the tonsillar bed. This is the superior constrictor. Arterial supply, it's through the branches from the facial artery, ascending pharyngeal, ascending palatine, and greater palatine artery branch from the. This is the diagram showing that sometimes it takes branches from the lingual artery, or the main from the facial artery, and the ascending palatine, and this is the ascending pharyngeal, and this is the greater palatine artery branch from the maxillary artery. Nerve supply, there's a lesser palatine nerve and the sphenopalatine ganglion, and through the glossopharyngeal nerve. The velopharyngeal sphincter, uh, it's between the nasopharynx and the oropharynx. It acts as a sphincter to stop regurgitation of food from the oropharynx to the nasopharynx. It's important in normal deglutition and also in speech. The posterior superior movement of the soft palate and the movement of the lateral pharyngeal wall muscles and movement of the posterior pharyngeal wall anteriorly and the uvula act as an important part of this sphincter. The function of the oropharynx, it's a common pathway for food and air, respiratory function, reflex actions in sneezing and coughing, and speech resonance, especially for vowels, and deglutition in the second pharyngeal phase of swallowing, and draining the mucus from nasopharynx to be swallowed.